Hello and welcome to Protocol 6.3 Selective Spinal Assessment. We have been approved by medical control to implement this training. This training will be approximately 20 to 30 minutes of video time followed by a quiz, which will hopefully test your competency in the material covered during this course. So again, this is Protocol 6.3. It is a medical control option. We have been approved by Dr. Leinbaugh. And once this training is complete and we have 100% compliance within our agency, we will be able to implement this training into the field. Some of the reasons that we're implementing this training, one, the overall cost of cervical collars. As you all know, they are actually not reusable. They're made for single-time use, and so the hospital has been throwing them away after each patient encounter for sanitary reasons, and we are trying to save a little bit of money in some respect, but also this will help us provide better patient care. Cervical spine immobilization with hard collars can actually cause a lot of damage to our patients. We've all had patients who the collar is applied and then they are still moving their head back and forth. That's because the cervical collar does not actually protect the cervical spine in the way that we think it does. It's more of a kind of uncomfortable reminder for patients to not move their necks, whereas the soft cervical collars that the hospitals use are actually a better protective device for patients. Okay, let's jump in. So, spinal cord injury may be the result of blunt and or penetrating trauma, compression forces. It could be caused by abnormal motion, such as hyperflexion, hyperextension, hyperrotation, lateral bending, or distracting, such as a hanging, for instance. Compression forces, things like axial loading. So you have a patient who falls and lands in a standing position, say on their heel. That's going to create an axial load going straight up through the spine, causes your spinal column to actually compress. Or the blunt and or penetrating trauma, being struck with something or having some kind of a penetration trauma such as a stabbing or a gunshot wound to the spinal cord could potentially cause some detrimental damage. Most spinal results from motor vehicle crashes, we see a lot of falls. Falls is one of our number one calls that we go on. Firearms, recreational activities is definitely a big one. Spinal injuries may be classified into sprains, strains, fractures, dislocations, and or actual cord injury. Along with that, you have to keep in mind that we don't necessarily base trauma off the mechanism, but we do have to utilize that along with the story and our findings on our assessment of head to toe to try to figure out what is going on with our patients and what potential injuries they may have internally. So classifications of cord injury. So we have complete or incomplete. A complete injury, cord injury is permanent damage to the area that's affected, resulting in paraplegia or tetraplegia. So paraplegia would be, say, paralysis of both arms or of the entire right side versus the left side, whereas tetraplegia would be all four extremities. Incomplete would be partial damage to the spinal cord. Damage is going to be dependent on the area affected and the severity. So that means that depending on where on the spinal column the injury has occurred, you will have different severities and different potential losses depending on the location. Just to kind of go through some of the different areas and things that can happen with them. So high cervical injuries, so like C1 through C4, they're going to be the most severe of the spinal cord injury levels. You can have paralysis in arms, hands, trunks, legs. Your patients may not be able to breathe on their own. They might not be able to cough, or they might not be able to control bowel or bladder movements. Their ability to speak can sometimes be impaired or reduced. when all four limbs are affected. This is tetraplegia or quadriplegia, as many of you have heard. This is going to require complete assistance with all daily living activities. Some might still be able to use powered wheelchairs depending on the controls that they have, but most won't be able to do much of anything on their own. Low cervical injuries, so C5 through C8, it's going to correspond nerves to control arms and hands. A person with this level of injury may be able to breathe on their own and speak normally, but they're going to have various mobility issues. C5 injury, a person can raise his hand or her arms and bend their elbow, likely to have some partial paralysis or total paralysis of the wrists and the hands, maybe the legs. They can speak, use the diaphragm, but breathing is definitely going to be weakened, which makes them more susceptible to things like pneumonia. C6, nerves can affect the wrist extension. Paralysis can happen in the hands, legs, or trunk. Usually they're still going to be able to have some motion. Again, they can speak and use their diaphragm, but breathing is still going to be weakened. Let's move on to C7. So nerves control the elbow extension and some finger extension, so they're going to have some fine motor movement issues. Most daily activities are still going to be performed by themselves, but they might need some assistance with more difficult tasks. They may also be able to drive some kind of an adapted vehicle that's been customized to their ability levels. C8 controls some of the nerve and the hand movements. Should be able to grasp and release objects, although those the mobility might be weakened somewhat. Thoracic nerves, so T1 through T5, these are going to be affecting the muscles of the upper chest, the mid-back, and the abdominal muscles. Arm and hand function usually is normal. They can sometimes affect the trunk and the legs as well. Most likely, they're going to be in a manual wheelchair if this area is damaged. They can, however, still do most daily living activities and still be able to drive somewhat of a modified vehicle. T6 through T12, these are going to be muscles of the trunk, abdominal, back muscles, depending on the level of injury. You're going to have various results, so typically it ends up in paraplegia. Normally, they're still going to have upper body movement that is normal for them. Fair to good ability to control and balance the trunk while in a seated position, and should be still able to productively cough because the abdominal muscles are still intact. They're not really going to have much voluntary control of the bowel or the bladder, but sometimes with some special equipment they can manage on their own. Most likely are going to be in a modified wheelchair and vehicle. L1 through L5, usually these injuries result in some loss of the functions of the hips and the legs. Not really going to have any bowel or bladder control, and depending on the strength in the legs, they might need a wheelchair, or sometimes they'll be able to walk with a brace. Sacral nerves, S1 through S5, injuries generally result in some loss of function of the hips and the legs, little or no voluntary control of the bowel or bladder. Most likely will still be able to walk in this instant. Please remember that longboards are no longer a standard of care. There is still a place for longboards, however, so let's not completely forget about them. They're great for extrication, and there is still some subset of population out there who has a trauma occur where a backboard should be utilized for protecting the C-spine. All right, let's jump into different types of cord injury. There's essentially three types of cord injury that we reference, and we've all learned them at one point or another, but they're something that a lot of us forget about as we kind of move on. So central cord injury is going to be the classic elderly patient who falls and they hit their chin, causing an extension in the injury of the neck. Distal or upper extremity motor function is most medial in the spinal cord. These are the areas that are typically going to be affected with some patchy sensory loss. Central cord syndrome can often be missed in the emergency room because the imaging in these patients usually looks fine. Their sensory deficits can be kind of sketchy, patchy, You really, at times it seems normal, at times it seems kind of abnormal, but it is clinically diagnostic. It's very important for the ER as well as for us to consider this as central cord injury when assessing these patients, because oftentimes it can be overlooked. There is a mnemonic that we can utilize for central cord syndrome. It's called MUDE, so MUDE. M stands for motor or sensory, upper extremity, lower extremity. D, distal and proximal, extension injury for E. So that, again, MUDE. So M stands for motor and sensory. U, upper extremity over lower extremity. D, distal, proximal, and then E for extension injury. So typically you're going to have some weakness to the bilateral upper extremities with less severe weakness to the lower extremities. So again, referring back to U, so upper extremities, lower extremities. Again, you're going to have some difficulty urinating with lack of sensation. So motor control, being able to control your bladder. Also, this can affect your bowels as well. Moving on to anterior cord syndrome. So anterior cord syndrome is an injury to the anterior portion of the cord that's going to be affected. It is a flexion injury. So this is typically due to an injury to the arterial spinal artery. And this may occur as a result of vascular or atherosclerotic disease in the elderly patients. Those are going to be the primary targets. Our primary population affected. This can also be iatrogenic, secondary to cross-clamping of the aorta. These patients have preserved functions in the posterior column, and so their proprioception and vibration sense is intact. However, the anterior portion of their cord can be affected. Therefore, they tend to have bilateral loss of motor function, light touch, pain. Their temperature sensation can be disturbed below the level of the lesion. So these are all different symptoms that we want to make sure that we assess for and document appropriately, but also the appropriate facility to be having these patients transported to is critical. Any patient who we suspect some sort of a cord injury should be transported to BMC, as that is our trauma center. Next is Brown-Séquard syndrome. So this is a hemicord injury, typically in penetrating trauma, injury to the dorsal column. It causes ipsilateral loss of motor function, proprioception, vibration, loss of pain, and temperature. So this can cause ipsilateral loss of motor function and proprioception or vibration. So proprioception is going to be the perception or the awareness of the position or the movement of your body. And then loss of pain and temperature. So the patient will have injury to the dorsal column or the corticospinal tract and the spinal thalamic tract, which is going to cause all of these different symptoms that we just kind of went over. They have contralateral loss of pain and temperature as well. All right, now it's time for the special question. What is 2 plus 2?